We are here again with our new session in the series of 12 webinars, which are brought to you by GP Clinics through our own digital platform, docizlive.com. Just to inform you that last month session on vomiting could not be held due to some technical problems. Sorry for that. For those who have joined new, I am Dr. Anupam Agarwal, publishing GP Clinics, which is a CME journal for family physicians, and it is being published for last 12 years every month. Today, it is our 5th webinar in the series, and the subject is Vomiting, Look Beyond GI System. The recordings of all the previous 4 sessions on fever, cough, diarrhea, and constipation are available on our website, gpclinics.in. And summary of each session with question and answers is published in GP Clinics every month. I hope all of you must be getting GP Clinics regularly.
Hello, sir. Yes, sir. Continue.
I hope all of you must be getting GP Clinics copies regularly. And the summary of each session is there also in that going digital column. One important announcement I wish to make today, that we are giving Amazon bestseller book titled What Doctors Must Learn by Dr. Y.K. Amdekar, worth rupees 900, free with all print subscriptions of GP Clinics. The book covers essentially 3 finer points according to me. I've gone through that book. Whatever we missed during our medical training, or we forgot, or we were not taught. So all these points are there in this book. And all in all, I will say it's a good book to go through even at this stage to enhance our medical practice. Speaker for today's session is again Dr. Y.K. Amdekar, who needs no introduction. He is a pediatrician for last 50 years. He is currently a visiting consultant to SRCC Hospital, Mumbai, and has been the faculty to Grand Medical College, JJ Group of Hospitals, and Institute of Child Health, Mumbai. He has been the past president of IAP as well. So over to you, sir.
Thank you, Dr. Agarwal, and good morning, friends. I think today's topic, vomiting, is something that we see so commonly, but it is not always a problem of a GI system. And that's why today we are going to discuss how we approach this problem and how we manage it in our routine office practice. Can I have the next slide, please? Now, as usual, we start with just the basics so that we understand how to approach the problem. I think vomiting and regurgitation are 2 different things. Vomiting is an involuntary, very forceful expulsion of contents from the stomach or even sometimes from intestines, whereas a regurgitation is just an easy return of ingested food, often from the stomach into the esophagus and often out from the mouth without much force. This is important, especially in young infants who often regurgitate, but the parents might call it as a vomiting, and that is quite different. Nausea is a sense of vomiting. Many children will have nausea but end up with vomiting. But a nausea has an important correlation to vomiting, and we will discuss it as we go along with that. But what is more important to understand for all of us is vomiting may not be just a primary GI symptom. And of course, GI symptom does cause vomiting, especially in upper GI, which could be due to inflammation or obstruction. But don't forget the secondary causes, secondary to CNS disorders. And 2 types of CNS disorders cause vomiting. One where the vomiting center is stimulated by some biochemical abnormalities. And the other is also stimulated by the raised intracranial tension. So when you have a brain tumor or a meningitis, you have a raised ICT that stimulates the vomiting center in the trigger zone in the pons, and also some abnormal metabolites, and we will see the examples of each of them. But besides the CNS stimulation of varieties of causes, any stress also causes vomiting. For example, when a long distance runner in a marathon ends up often with acute stress and may vomit, similarly, a child who is frightened may end up crying and vomiting. And sometimes even a severe cough ends up with a vomiting, where the parents talk about vomiting more than a cough. And please take a note that several systems can be responsible for the cause of vomiting. Having understood this, the next slide, please. Now, this is an interaction for you. Okay. I want you to select which of these four options are right. Vomiting may be caused by ear problem, renal disease, adrenal disorder, or all of the above. Your time starts now. Excellent. What a good start to our webinar today. Everybody mostly said that it could be all of the above. I am aware you all have seen chronic renal disorders who may have vomiting, and of course, adrenal disorder. And both of them may not be very common. Adrenal disorder, especially, is much less common, but it is important. And I'm so happy that few of you also have thought of ear problem, renal and adrenal. And don't forget that even a ear problem like a vertigo, for example, okay, can end up with vomiting. And to that extent, this tells us that how vomiting can come from varieties of systems in the body, though we primarily address vomiting to GI system and at the most spread over to our thinking to a neurological problem. But even beyond that, ear problem, renal disease, adrenal disease, and of course liver disease, many of them can cause it. But I'm so happy that majority knew that any of those systems can do that. The next slide, please. So now, having understood that vomiting could be caused by varieties of systemic disorders, and therefore it's important to think beyond GI system. Can I have the next slide, please? The next slide, please. Now, just to make you understand what is the natural response to vomiting, there is a lot of salivation, which is intended by nature to protect the enamel of teeth. There is a retroperistalsis from intestines with relaxation of the pyloric sphincter. Then there is also glottis that is closed, which normally prevents aspiration out of vomiting, though this mechanism may not function well in young infants or even in old age. And that's how vomiting can lead to aspiration complications, and even in old age, even a sudden death due to large aspiration. There is an increased intra-abdominal pressure with relaxation of the esophageal sphincter. And don't forget that there is often a lot of sympathetic stimulation which results in sweating or tachycardia. And these are the natural responses to vomiting. Let's get to the next slide, please, now. And the next slide shows you a clinical approach to problem of vomiting in your office practice. When vomiting is a first symptom, the story starts with vomiting. It's usually a primary upper GI problem. Whereas if the vomit starts a little later in the course of illness, it often is secondary, or it could be a lower GI. Persistent vomiting always beyond 2 days is usually serious. So the point I want you to note is that onset symptom is extremely important. A typical esophageal or a gastric problem starts with vomiting as the first symptom, whereas a vomiting may come up a day or two later in a lower intestinal problem, or it may often be so in a non-GI problem like a neurological or a metabolic problem. But one thing is sure, that if vomiting lasts beyond 2 days, take it seriously. It's something that will just not stop naturally. It's something that will not be corrected by just an antiemetic. And I think that is very, very important. Now, the content of vomitus often gives you an idea where the site of the disease stays. And commonly, it's an ingested food particles that come out. And after that, when the entire stomach is emptied, you might just get mucus secretion or even sometimes a bile stain, especially when there's an obstruction beyond second part of duodenum. Of course, there is a bile stain vomiting. But don't forget that repeated severe retching may also result in a little greenish vomit or sometimes even a little strain of blood or so. But when there is a large amount of blood in a vomit or a coffee ground blood coming, then it's definitely a hematemesis. And very rarely, you might also get a fecal vomit, especially in a gastrocolic fistulas. Certainly not common, but in adults, it may not be rare, especially in old age with multiple problems like the malignancies, etc. So it's important to note what's the content of vomit. And as usual, the associated findings give you an idea where to localize the problem. And one is could be an abdominal pain or distension. You may have a headache or drowsiness in a neurological disorder. You may have an edema or hematuria in a renal disorder. You may have a jaundice in a liver disorder. You may have a skin pigmentation, a characteristic adrenal disorder. Besides that, the vomiting also may lead to dehydration, hypotension, often hypokalemia and hypocalcemia. So when you look at the patient with vomiting and examine him, look at many things that might give you an idea where is the site of a disease. And don't forget to see whether there are complications occurring because of vomiting, like dehydration or electrolyte imbalance, etc. And I think this is a very simplified clinical approach. I'm nearly sure that with this kind of approach, almost every patient of vomiting, you can definitely come to a reasonable, correct provisional diagnosis. Now, having given you this idea about the basics and the clinical approach, let me, as usual, take you through some case scenarios. And every case, you will give your opinion. And let's start with that. So let's have the next slide, please. The next slide, please. Now, this is your first case. Now, here's a 2-month-old infant who presented with recurrent vomiting for the last 2 weeks. Vomitus contains curdled milk. The child is restless before vomiting, but feels relieved after vomiting and takes sweets well thereafter. Physical examination shows a mild fullness in the epigastrium. Please note recurrent vomiting for 2 weeks, curdled milk coming out in a vomit. Child is restless but is relieved, feels very well thereafter, and has a mild fullness in the epigastrium. Your choice is gastritis, hepatitis, gastroesophageal reflux, or a pyloric obstruction. Your time starts now. Fine. The large number of you have said it could be a pyloric obstruction, but a few of them have said it could be a gastroesophageal reflux as well. Of course, none of you have said it's a gastritis or hepatitis, and you are so correct on that. Now, look at the whole story very, very correctly. One is that there is a curdled milk coming out. Obviously, it means that the milk is going into the stomach, staying there for some time, and then it happens to be curdled. But when he vomits, there is no milk in that at all. It's only the curdled milk, which means that the ingested milk has stayed in the stomach for maybe 15 to 30 minutes for it to be getting curdled. So one thing that you understand is that this child has no obstruction up to the stomach anywhere, and the problem starts sometime after 30 minutes or so of having had the milk going into the stomach. This much we knew. Second is it's a recurrent problem for last 2 weeks. And the third is just before vomiting, he becomes restless, but once vomit occurs, he's all fine. And lastly, take a note that there is no cough at all. So he's not aspirating anywhere into the gastroesophageal reflux. Okay, which is a common cause of that. Two things. Gastroesophageal reflux does not cause very recurrent vomiting over a short period of time. This is just 2 weeks. And second, there is no cough at all, which is very unlikely in a small infant with gastroesophageal reflux. And therefore, this is most likely a pyloric obstruction. What is another point in favor of pyloric obstruction? One is that moment the child vomits, feels very relieved. Now, any mechanical cause, when it gets away from the body for a while, the patient feels absolutely all right. But if it's not a mechanical cause, but an inflammatory cause, like a gastroesophageal reflux is an inflammation, esophageal inflammation. So even if the child vomits, the child is not still feeling very well. So for varieties of reasons that I explained, but I'm sure that many of you may not be terribly wrong to say, could it be a GER? But I wanted to bring out the subtle differences between these two conditions. And now I'm sure you have typically found out how to dissect between these two common situations. Gastritis is really a throwaway diagnosis. When we do not understand what the problem is, we call it gastritis. But gastritis certainly occurs, but often in an older child or an adult, and often is associated with some burning in the epigastrium and retrosternal, and that is classical. And it has also relation to feeding. And I think that's why it is certainly very, very uncommon. Fine. So let's, I think, get to the next case. As usual, we have 8 cases to go by. And this is my second case for you. Go back. Case second, go back. Yes. Now, this is a little older child, 8 months old. And he presented with vomiting and cough. It's off and on for last 1 month. And he would vomit sometimes while feeding. And vomitus contains only milk, not the curdled milk. Take a note of all these small little things. And this also tells you how you should take a very good detailed history. Take a note of how the first phase is different than this. This is the little older child. He's getting off and on. That means in between he has no vomiting. At some other time he's vomiting. But he's vomiting right while he's feeding. Okay, and vomitus contains milk only, no curdled milk. On examination, there is nothing at all. Your options are gastritis, esophageal obstruction, gastroesophageal reflux, or a primary respiratory disease. Your time starts now. Excellent. Okay. Majority of you have said it's an esophageal obstruction or a gastroesophageal reflux. Majority of you are putting your finger on one of these two, though now you all have understood gastritis is not really a diagnosis to make at all. Now let's discuss all these three conditions. Primary respiratory disease has a cough as a predominant symptom and not vomiting as a predominant symptom. And only when the cough is very severe, that may end up with vomiting, but a patient presents with cough and also may vomit, but this child is presenting with vomiting, and that is important. Okay, though there could be cough as well in a child of vomiting, yes, but this child has vomiting as the isolated symptom. That is number one. Second is that if the vomitus contains only milk and no curdled milk, it means that ingested milk has hardly remained in the stomach or even gone into the stomach. Last time we said in a pyloric stenosis, the milk has to stay there for some time. Here, the milk doesn't stay for a longer time or may not stay at all. And that is another conclusion, that this child's milk is not staying in the stomach for some time. But what more information I have given you? The child vomits while feeding itself. He doesn't wait for a feed to be completed. Okay, as he feeds, he is vomiting. This suggests that the milk may not reach mostly the stomach at all, or it could just trickle down into the stomach and nothing beyond, but the majority is just coming out much before it stays in the stomach. And this is classically seen in an esophageal obstruction. Now, esophageal obstruction is of two types. One is called achalasia, which means that the esophageal muscle does not relax. And because it does not relax, it has a functional obstruction. Of course, the obstruction could come from anywhere else, either inside the esophagus, any mass, or a mass pressing from outside, but those are a chronic progressive vomiting and not vomiting off and on. So you can see the small difference between the two, right? And again, make a note that this is where we stand. A typical GER has a cough as a predominant symptom and also vomiting. So again, a small difference, and a GR often allows the feed to go into the stomach, and as the stomach enlarges with the feed nearly completed, you get a reflux coming out. So these are the small, subtle differences that I wanted to bring out in these conditions. And again, making a strong point that how important is to get such a detailed history, to get to a very subtle differences between diseases which look very similar to each other, but with a good history and a good thought behind the history, one could almost differentiate all such conditions which look very, very similar. Good. But let's get to the next slide, please. Now we have a third situation, which is something similar. Can I have the next slide, please? So my next slide is the third case. The slide is not fully seen here. Okay. Can somebody make a note of this slide? But I know the story, but I will tell you the story.
Hello. Can I read the history?
Yeah.
Can I read the history? Yeah.
Yes.
It is a 4-month-old infant presented with vomiting while or immediately after feeding for the last 1 month. Demands frequent feeds, breast and bottle feeding. Has been irritable, not gained weight over last 1 month. So this is the history.
So I think again the difference between the last two cases and this is also an infant, and he's also vomiting, but he is certainly not a normal child even after vomiting. He seems to be irritable. Irritable means generally the pain, and also he has lost weight. So now take a note of this. This child's vomiting looks similar to the first two situations largely, but the difference is this child is a sick child and not acutely sick, but chronically sick. That's why he has lost weight also, and he has possibly some pain somewhere. Now, your options are gastritis, upper GI obstruction, gastroesophageal reflux, or none of the above. Your time starts now. Excellent. What a perfect thing. Okay. Majority of you have said it is likely to be upper GI obstruction. Okay. And very few of you have said it's none of the above. Now you're getting some changes on that, but that doesn't matter. But only 4.3% have said it's a gastroesophageal reflux. I'll give you again a subtle differences between that. Okay. See, on this webinar, I am sure those who subscribe to GP Clinic and those who are attending such webinars and many other educational exercises that the GP Clinic goes through are those practitioners who want to learn all the time. And I'm sure that medicine is something which is so dynamic that at the end of 60 years, I became a doctor in 1963, almost 60 years ago. And even today, I need to learn because there has to be a continuous learning. And I can see that when you all attend such seminars, I know that you are very much inclined to continue learning. And that's why I thought that this group who attends must have something different and more thoughtful or thought-provoking cases so that you understand the nuances of the small, subtle differences. Now take a note of this child. This child is sick. This child is irritable. This child has lost weight. What does this mean? There is some chronic condition. Okay. Now, an upper GI obstruction is a persistent condition and not the recurrent vomiting. Okay. Now, the loss of weight in a child like this and being irritable. I said irritable generally means pain. And so this is a painful condition. And rightly so. Some of you have called it a gastritis. So I did mention earlier that gastritis is generally a throwaway diagnosis because when we don't understand, we call it gastritis, but certainly not a common definitive diagnosis mostly. Therefore, this is typically a GER doing that. I did not want to bring out a lot of other symptoms of GER, but I wanted to bring an attention to you that a GER has an esophagitis because the acid from the stomach is coming into the esophagus. There is an esophagitis, and that is causing irritability. That is number one. And esophagitis is an inflammation. And this is the chronic persistent inflammation. Even if vomiting is recurrent, the inflammation is persistent. And that causes a loss of fluid and also a lot of nutrition and blood loss due to inflammation, and therefore the child is losing weight as well. And I think this is characteristic of a chronic persistent inflammation. There may be cough, there may not be cough. Often there is a cough. But what I wanted to bring out in this child is a chronic persistent inflammation, and evidence of which is presented by an irritable child and also losing weight. A mechanical causes almost never lose weight unless it is a persistent obstruction. And this is going on recurrent for last 1 month or so. And therefore, this is a typical GER coming. Again, as I mentioned, I wanted to bring out these subtle differences between these three conditions only because I know that the people who are attending this are looking for something more to learn than what they are already expert in. And I think that's why I wanted to bring out some such a little different and may be often seen by all of you, but sometimes not easy to pick up. Of course, the investigation would make you diagnose this, but I'm going to harp a great deal on how a clinician in his own office can diagnose many things correctly. And I think it gives you a thrill of having diagnosed correctly. You, of course, will have to do some investigations and confirm it, right? Fine. So let's go to now a little different types of cases. And can I have the next slide, please, which is my fourth case coming up. Fourth case. This is next case. That's right. Again, I'm not seeing the whole slide. I don't know why I'm not seeing the whole slide, but I could see the whole slide just now of course 3.
I think there is some.
Can that be put up
there
here?
Is some technical glitch. So I read the case for history, if you permit. It's a 4-month-old healthy infant presented with acute onset of vomiting, followed the next day with drowsiness. Physical examination reveals nothing abnormally detected. Over to you, sir.
Fine. So again, this child has an acute onset of vomiting, but it is followed by drowsiness. All this is of a very short duration. Take a note of that. Short duration, vomiting followed by drowsiness. There is no fever. And this is a young infant. And having seen this, now your options are meningitis, brain tumor, hepatitis, or it's a metabolic disorder. Your time starts now. Again, we are getting a little divided opinion, though almost nobody considers it as hepatitis, and that's so correct. This is not a hepatitis at all, right? So, quite a few of you have favored equally a meningitis or a metabolic disorder, but nobody is talking about hepatitis, and very few have talked about brain tumor. Now, I'm so happy that nobody calls it hepatitis. It's so clear. And now, as the time goes, I can see that very few consider it as a brain tumor. Some of you consider it as meningitis, but a majority of you, a small majority, just past 50%, think it's a metabolic disorder. Now, let's dissect all this. One is a brain tumor is often a slowly progressive chronic disorder. And this child doesn't have that. Second is a brain tumor often presents with headache and vomiting. Headache may represent irritability in a small child, but not drowsiness. And therefore, it is not likely to be a brain tumor. That's number one. Because no headache, no irritability, and acute onset. Brain tumors are rarely an acute onset unless you call it a sudden acute hematoma in the brain. But that doesn't happen all of a sudden in a normal person. So it is not a brain tumor. Why is it not meningitis? Because meningitis always, acute meningitis always starts with fever. And this did not start with fever, though unfortunately we could not show you the slide, but there was no fever mentioned. And I did mention in my discussion that there is no fever. Now, no fever almost rules out any possibility of an acute infection, and therefore it is an acute metabolic disorder. Well, what metabolic disorder? One may guess, but there is no reason to discuss that further at all. This child needs urgent hospitalization and investigations right on day one, because this is a metabolic disorder and we would need some investigation to come to conclusion, right? So these are the differences of that. Come, let's get to the next slide. But when you put the next slide, stay with that. That is likely to be, yes, wait. Don't change. No, don't. Now, this is now case 5. Yes, we are getting the right entire slide on this. Now, this is a little older child who presented with vomiting for the last 1 month. Make a note. Vomiting for the last 1 month, has lost weight. On direct questioning, parents reported constipation, extreme irritability, severe anorexia, and constipation and polyuria. Imagine now, this patient tells you that history can go beyond. When somebody came with vomiting, you must ask, what about any other symptom? Parents might say no other symptom, but they may not consider constipation or severe anorexia or irritability as something important. And take a note, polyuria is often missed unless you ask for it. Now, this child has all of that. Now, your options are, is it a lower intestinal obstruction? Is it diabetes? Is it meningitis? Or is it a renal disorder? Your time starts now. Your time starts now. Good. None of you called it meningitis. So correct. Though the house is divided almost between lower intestinal obstruction mainly and diabetes and renal disorder in the other. The story has a chief symptom of vomiting, and therefore a diabetes does not have a chief symptom of vomiting. It has a polyuria, polydipsia, yes, polyphagia. But vomiting in a diabetes is only a complication, if at all, but not just a vomiting as a prominent chief symptom. And therefore, take a note that though polyuria, polydipsia, yes, but I haven't said excessive thirst. I've just said polyuria. Okay. Now, typical diabetes is polyuria, polydipsia, both, and excessive intake of water. This cell has polyuria, but not other things. So this is not diabetes. Could it be a lower intestinal obstruction because of constipation? But why polyuria? In fact, when you have a lower intestinal obstruction, rarely presents with vomiting. It presents with constipation as the first symptom and also abdominal distension. Here, the story starts with vomiting. Therefore, a lower intestinal obstruction starts with constipation and vomiting is a later symptom. How important it is to pick up what starts and what follows thereafter. And therefore, this is a renal disorder. It's not important what kind of renal disorder. Yes, it's a renal tubular disorder. And as you know, polyuria could be a symptom of not only diabetes, but also the hypothalamus pituitary axis or also the renal system. Renal tubular disorders present with polyuria, whereas many other renal disorders present with oliguria. And again, I wanted you to be taken to a little higher level of understanding how each symptom and the onset of symptom and the progression of symptomatology makes the difference between a final thought process of a provisional diagnosis, right? So this has been a renal disorder. Can we go to the next slide, please? The next slide, please. Now we have the next 8-year-old healthy child who presented with an acute onset of vomiting, severe anorexia, mild fever, and lethargy for 1 day. No other symptoms. Physical examination normal. Take a note, acute onset, but accompanied with severe anorexia, very mild fever, and lethargy. Not drowsiness, not unconsciousness, lethargy. Now your options are, is it meningitis, is it hepatitis, is it brain tumor, or is it none of the above? Your time starts now. Again, so good that no one is considering meningitis at all. Extremely important. Fever is mild, and fever is not a major symptom of this child. Meningitis would have started that, and gradually you are all moving on to hepatitis. So correctly. Brain tumor, as we said, is not an acute onset condition. Okay, meningitis starts with high fever before vomiting comes up. The story of an 8-year-old child with meningitis would be high fever for a day or two, irritability, and then vomiting. Well, this child has mild fever, but vomiting is a predominant symptom. And therefore, it's not meningitis. It's not brain tumor because it's an acute onset. We said that. And this is typically an acute hepatitis. What is typical of acute hepatitis? Two things. One, a severe anorexia. They even don't want to look at the food, and even if they look at the food, they vomit. It's such a severe anorexia. Is a classical story of a viral A hepatitis, and feeling very tired is another classical symptom of an hepatitis. So this was a typical acute hepatitis, and again, I wanted to bring subtle issues, how you differentiate one from the other. Let's get to the next slide, please. You have a 7th case coming up now. The next slide, please. Next slide. Now, this is another older child who presented with severe periumbilical abdominal pain and vomiting, but vomiting not bile stain, and mild fever for a day. Make a note now. This child's chief complaint is severe abdominal pain, periumbilical, and also vomiting, which is not bile stain, and very mild fever, all of a short duration. Okay, so presenting symptom of this child, major symptom of this child is abdominal pain and not vomiting, but also vomiting. The physical examination showed a generalized mild tenderness without guarding or rigidity. Your options are developing acute gastroenteritis, intestinal obstruction, acute appendicitis, or acute pyelonephritis. Your time starts now. Well, almost nobody is calling it as acute pyelonephritis, which is so correct, because acute pyelonephritis never causes vomiting as a major feature. Often it's a chronic renal disorders which cause vomiting. But yes, But acute pyelonephritis is a high fever, and abdominal pain is not a chief complaint. On direct questioning, you get some pain which is referred to the bowel. So that is not a possibility. But majority of you have favored acute appendicitis, and that is so correct. The point is, if this is a developing acute gastroenteritis, then pain is not a feature. A vomiting is the first feature. After all, it starts with gastro and becomes enteritis. So vomiting is the chief complaint, and abdominal pain is not a chief complaint. So it's not, and at this age, it is not gastroenteritis, often gastritis you might call, but again, gastritis is not a periumbilical pain. It's an epigastric pain. So it is not. It is not an intestinal obstruction because vomiting, abdominal distension are typical features, and vomiting is a chief complaint, maybe also with abdominal pain. So this is less likely. But don't forget, acute appendicitis starts with a periumbilical pain and then moves on to the right iliac fossa after 24 hours. Normally, we diagnose acute appendicitis with a right iliac fossa pain, but on day one, and I'm sure most of you will see acute appendicitis coming on day one with a severe abdominal pain, unbearable often, but just a little vomiting and just little fever. But that periumbilical pain should not misguide you to miss a diagnosis of acute appendicitis, because to begin with, appendicitis is pain is caused by the inflammation of appendix, but over the next 24 hours, even a peritoneum gets inflamed, and that is the time that it settles down to where the appendix lies in the right iliac fossa. And therefore, this was the typical acute appendicitis. Again, I wanted to bring not a right iliac fossa pain, but a periumbilical pain on day one as a case of an acute appendicitis. Can we have the last case of this series? The next slide, please. Now, this is the last case where 8-year-old, again the older child, again take a note that when I'm presenting older children, they also represent the problems in adults. And that is where we have a common link between some pediatric patients and some adult kind of patient. Therefore, this is an 8-year-old child who presented with vomiting and headache, gradually worsening over the last 1 month, no other symptoms. Physical examination showed an obese child. There was papilledema, but MRI was normal. Take a note. Again, I'm bringing out some small differences. This is a chronic progressive headache and vomiting showing papilledema and in an obese child. But when MRI was done, MRI was normal. Now your options are chronic meningitis, brain tumor, hypertension, or none of the above. Your time starts now. Well, none of the above nobody has volunteered to put a finger on, and it's equally divided almost between all three conditions. Now, chronic meningitis has no severe vomiting or severe headache, and it's not slowly progressive, and therefore there is no fever either. The chronic meningitis is due to a chronic infection like tuberculosis, for example, and often there is some suggestion of a chronic infection in terms of low-grade fever, etc. And the disease is not very quickly progressive. And to that extent, this is unlikely a chronic meningitis. Often, a chronic meningitis has also some behavior disturbances and a brain cell affection. That is not there in this child. A brain tumor, yes, the story looks like a brain tumor, but an MRI is not showing brain tumor. But those who are 19% of you have voted for brain tumor, this is the classical story of a brain tumor. A slowly worsening headache and vomiting is a classical story. And the clinical examination showed a papilledema, which is in favor of a raised intracranial tension. And one would not have been wrong in suspecting brain tumor. And that's why MRI was done in this child. But MRI did not show a brain tumor. Again, hypertension presents not with vomiting as a feature. Headache could be a feature, and often a chronic progressive hypertension may cause breathlessness because of a cardiac situation. But vomiting is not a feature. And therefore, I just wanted to bring another complicated situation that it presents like a brain tumor, but it is not showing brain tumor on an MRI. But take a note, this child is obese, and this is known as a pseudo-tumor cerebri. Extremely obese children present like a brain tumor, but do not have a brain tumor. And it is simply a complication of their excessive obesity. It is called as a pseudo-tumor cerebri. Not certainly common, but you might be seeing many adults who are extremely obese, and they may also have a hypertension, but they may also have a pseudo-tumor cerebri that present with vomiting. Having said that, in the next 5 minutes, let me take you through the remaining 2-3 slides. Can I have the next slide, please? The next slide, please. Now we have a small interaction here again. Which of the following drug can fully control vomiting? That means you give a drug, now no more vomiting. Your time starts now. There is an ondansetron, there is a metoclopramide, there is a domperidone, or the answer is none of the above can do it, or any of the above can do it. Your time starts now. Almost you are 50-50, or now you're getting on to some others. But, well, majority of saying none of the above. Yes, you're right. I wanted to convey one important point to you, that no antiemetic can just stop vomiting, but may partially control vomiting. And that's why I made a mention in our basic discussion that if vomiting persists for more than 2 days, you have to investigate, because it is not naturally getting better. All naturally getting better, vomiting almost often stops at the end of 2 days. And do not continue antiemetic longer than that without investigation. Well, you can use an antiemetic because it may partially control, but not fully control. To that extent, for some hours, there may not be vomiting, but it's never easily controlled. And to that extent, yes, I wanted to just convey you to that. Can I have the next slide, please? Now, quickly talking about management, I think management all depends on exactly what is the cause of that. And sometimes you might need hospitalization, like for intestinal obstruction or a persistent vomiting in a hepatic renal or an adrenal disorder, a primary neurological disorder, of course, and even a secondary neurological, that is a metabolic problem. What have you understood? Whenever it's something beyond upper GI, vomiting may need investigations or hospitalization. And if the vomiting is related to upper GI, then you might stay with antiemetic for a day or two. And during that time, you maintain hydration. That is important. Well, exception to this rule of antiemetic for a day or two only is when a person having a malignancy is undergoing chemotherapy. One of the commonest side of chemotherapy is vomiting, and sometimes you might have to use antiemetic for a long time. But that is the only exception. What I want to bring out a point is that any vomiting that lasts for more than 2 days, don't just stay with an antiemetic. Get on to diagnose the several conditions that this slide mentions in the first part and pick up what is the exact cause of vomiting. And then, of course, the management depends on having diagnosed a condition. Can I have the next slide, please? And therefore, the take-home message now. You must be wondering why I did not do a lot on investigations and management. Investigation depend on what has been your provisional diagnosis. And once you have a provisional diagnosis, you know whether you need investigations alone or investigations and hospitalization. And therefore, I did not want to waste time on that. That I'm sure every one of you are so good at all that. But also, I did not want to waste time on management because management is also symptomatic only for a short time. Beyond that, the management consists of something beyond, depending on what your diagnosis is. And therefore, my take-home message is there are many happy infant spitters. They don't need any intervention at all. They are often regurgitating and not vomiting. Vomiting at the onset is often a GI origin, but if it lasts for more than 1 or 2 days, it could be something beyond. Persistent vomiting beyond day 2 always needs a proper evaluation. Accompanying symptoms gives you a clue to diagnosis, and anti-emetic drugs are not very effective, but may be tried only for a short time. I think having given all this, I am almost coming to the end of our 1 hour scope. But if there are only 1 or 2 specific questions, I think I hand it over to Dr. Agarwal to take it forward. Of course, all remaining questions coming directly, otherwise on email, will be answered and you will find them in your next GP clinic. Okay, back to Dr. Agarwal.
Okay, thank you, Dr. Amdekar, sir. For the interest of the readers, can I have just one clarification from you? Whatever cases we have covered or the discussion we had, that was largely favoring children. So can the same information be applied for adults as well? Yes, sir.
Yeah.
Am I audible?
Yes.
So can the same information be applied?
Yes, you are audible now. Yes, you are audible now.
Okay. So can the same information be applied for adults as well? I'm asking you for
No.
the interest of the readers.
Date for next one.
No. What I'm asking is that whatever cases we have covered, they were largely favoring children up to 8 years old. So can the same information, the answers and the discussion we had, can that be applied for adults as well, adult patients as well?
Absolutely. Absolutely. See, for example, barring first 2-3 years, the rest of them are a miniature adults for all practical purposes. I see appendicitis at 4-5 years of age. Okay, you see hepatitis at any age. You see a renal disorder at any age. You see a brain disorders at any age. So I wanted 8-year-old just to make a point that represents adults, and except the first 2-3 cases that I wanted you to pick up separately, because many of you may be seeing a young infants or toddlers coming with vomiting for varieties of reasons. And I wanted to bring out more subtle points of discussion and differentiation. Because as I told you, Dr. Agarwal, that I take this group as somebody who wants to learn more. And what more can I make them to give a thought process? That is why I brought. But I also took care of a brain disorder, an adrenal disorder, a renal disorder, a hepatic disorder, and also one who was obese and vomiting like a brain tumor, but was not a brain tumor. So you're right. My discussion largely also is applicable to adults. But as a pediatrician, I want you to also focus on first 2 3 years, which also you all must be seeing.
Okay.
I hope that is the right way to make this seminar, because I'm a pediatrician largely. So I'm not going to talk about my age vomiting,
Right.
old age vomiting, right? Yes.
Yeah. Good. So, because why I've asked this question is because many doctors are asking me that your discussions are focusing mainly on children. That's why I asked this question for clarification. I think readers,
That's right.
audience, it's very clear to you now that whatever we are discussing is applicable to all age groups, right?
Yes.
So, one doctor has asked, what is the best medicine to control vomiting of pregnancy and or in alcoholic people?
I think again the drug choice remains the same. Okay. Now, if it's a vomiting of pregnancy in the first 2 3 months that occurred, I think we all know that it's not easy to control really by drugs. Therefore, whenever the vomiting cannot be controlled by drugs, but there is no other way to also attend to the problem, I think what is more important is a counseling of a patient. So, whenever science fails, but the patient expects some improvement, counseling helps to tell them that this will just get over. This is natural. Don't worry about it. Just tolerate it. And I'm sure it's a good news for you that you are pregnant. And I'm sure this is going to stop in a very short time. And I'm going to give you some tips. For example, the tips beyond the drugs could be eat small amount of food at a time, eat frequently, but not a large amount. Take a rest. Don't lie down immediately after eating. Sit in a reclining position. All such simple thing and a good counseling would, I imagine, will help to take care of that early pregnancy vomiting. Of course, in a late pregnancy, if he is vomiting, then there is some other cause to that extent. So I suppose that is the way I would do it, not even as an obstetrician, but as a general physician attending to this problem.
And what about the alcoholic people?
Pardon?
Vomiting in alcoholic people.
Oh, vomiting in an alcoholic. Yes. Now, vomiting in an alcoholic could be of two reasons. One, it is a gastritis that is causing. And why is gastritis being caused by alcohol consumption? Only because he does not eat thereafter. An alcoholic should eat enough thereafter. But he has consumed so much of alcohol that now he does not want to even eat, and then he will vomit. So alcoholic gastritis is because you are not eating thereafter. I don't say that you have a lot of alcohol and eat a lot. Of course, alcohol is an irritation, but that is one kind of alcoholic vomiting. And again, there is no easy answer, but prevention is possible. Of course, the other is if an alcoholic is getting a chronic hepatitis or a cirrhosis, then a liver disease itself may end up with vomiting. So I suppose alcoholic vomiting is a very interesting question, but it can be rather prevented by taking enough food after alcohol. Of course, the best way to prevent alcoholic vomiting is don't take alcohol.
So the next question is, what does blood-stained vomit suggest?
So if the vomiting contains blood, then it's of two types. One, a small stain of blood, which is to be ignored because any severe retching and vomiting may have a blood stain. But if it is a larger amount, say a few spoonfuls, then of course it's something serious. Majority of the times it is a portal hypertension that causes such a large amount of blood vomited, but rarely it could be a severe gastric or a duodenal ulcer doing that, or in an adult and an old age, it could be even a malignancy in the stomach where you get a large amount of blood. So large amount of blood needs investigation. Majority of the happy, apparently not very sick people have a portal hypertension. Somebody who has an acute but severe epigastric pain may have rarely a severe gastritis or a gastric or a duodenal ulcer. And of course, in an old age, don't forget malignancy causing a large amount of blood vomit.
Okay. So next question is, are there any serious side effects of anti-emetic drugs?
Side effects of antiemetics?
Yeah, any serious side
I
effects
think,
of antiemetics?
yes, antiemetics have a lot of side effects. One important side effect which you cannot prevent is many antiemetics cause affection of the basal ganglia, and there are abnormal movements occurring. Okay, somebody who has taken an antiemetic suddenly starts clenching his teeth, making some funny movements. Okay, it is likely to be an acute onset neurological side effect, which is not a side effect due to large amount of antiemetic, but it is due to an abnormal response of this particular patient, and therefore extrapyramidal tract symptoms like a basal ganglia symptoms of an acute onset are often noticed with drugs like antiemetic. We do see that at times, and that makes you give some more drugs but continue antiemetic. This is a typical side effect of an antiemetic. Largely, otherwise, there are no major antiemetic effects. But yes, this is something that one often sees there. But antiemetics are not to be given for a long time anyway. And therefore, the only side effect that you may see even after the first dose of antiemetic could be an extrapyramidal tract symptoms. And then you stop antiemetic.
Okay. So lot many questions are coming up. Let us take just one last question. If cause of vomiting is not known, whom should we refer it to? Whom should we refer the patient to? Physician, surgeon, or a system specialist? An interesting question.
I think if vomiting persists beyond 2 days and there is no clue at all, it only means that the clue is likely to come up over time. Now, which are the conditions where a clue can come over time? One is a brain tumor. So you must ask in details whether this child has some complaints of headache. Now, what is the typical complaint of a headache in a brain tumor? Early morning when a patient gets up has a headache and vomiting, but thereafter he is all fine. Because during sleep, there is a little venous congestion in the intracranial compartment, and that added on to the developing brain tumor often starts with vomiting, headache on waking up in the morning, and thereafter there may not be any at all. So that might give you a clue. Oh, this is an oncoming brain tumor coming up. But as I said, oncoming. Another oncoming vomiting could be a chronic renal disorder. But if you look minutely, this child has some chronic renal symptom. He is not growing well. He may have a renal hypertension. He may have a mild edema somewhere. He may have an oliguria somewhere, which he has not reported to you. So chronic renal disorders won't be hiding. So the vomiting could be just without clinical examination finding. Do the chronic liver problems cause vomiting like this? No. They have many other symptoms before vomiting. But an acute hepatitis may start with vomiting, but generally also accompanied with severe anorexia and lethargy. So that also can be picked up. But only other vomiting, which can go on for a week or sometimes even few weeks without any clue, is an adrenal vomiting. An adrenal depression caused by adrenal hypoplasia or by rare disorder may just cause vomiting alone. So I would say if vomiting is without a clue for a 1 week, look for a subtle clue in neurological disease, like a brain tumor coming up, or look for an adrenal disease. But lastly, don't forget about functional vomiting, totally because of mind. And how can you pick up a functional vomiting? Simple. This is all functional disorders, I call them as a symptom of convenience. They come only when it is convenient for a child to come up. Okay. So when it's a time to play, there is no problem. When there is a time to sleep, oh, sleep happily. When there is a time to eat, very enjoying meals. But when there is something not wanting to do, a symptom comes up. It could be headache, it could be abdominal pain, it could also be vomiting. And therefore, look for a symptom of convenience and call it a functional vomiting. These are the conditions where there is no clinical clue, but you could easily pick up that. Adrenal disorders are rare, but I wanted to bring that also point to you. Brain disorders can subtle early morning problems. The others have enough clues right to begin with by day to day.
Okay. So I see a lot many questions are trickling in. So with your permission, sir, we can cover all those questions with answers in our next issue, GP clinics. So now we are coming close to the session. Now I thank you, Dr. Amdekar, for this wonderful session. I'm sure all the doctors who are attending this session would have liked it. We hope this
But
interactive
Dr.
session would
Agarwal,
have made learning
I
interesting.
wanted to say that the
Yeah.
question that you put up were very different and made me also think how to answer them. But they were very interesting questions. Thank you for them.
Okay. Thank you. So I hope this interactive session would have made learning interesting to help empower your practice. On behalf of GP Clinics and DocIsLive.com platform, I thank all the doctors who have attended this session. And I am seeing that over and over, as we are moving on, more and more people are joining up. And it's good to see and very encouraging for us as well to do more. Please note the date for the next webinar, that is 18th December, Sunday, 11 a.m. The topic would be abdominal pain. Beware, it is a Pandora's box. It's going to be a very interesting session. So thank you once again to all of you. Good day, all of you.
Good day to all of you. Thank